Our focus is on rheumatoid arthritis, or RA, particularly when it appears as part of an overlap connective tissue disease scenario. This perspective is crucial for clinicians because overlap cases can blur diagnostic lines, and management requires careful integration between rheumatologic and systemic viewpoints. Let's walk through the definition, pathogenesis, clinical features, investigations, complications, and practical management approach, step by step. Definition. What are we talking about? Rheumatoid arthritis is a chronic systemic autoimmune disorder that primarily targets the synovial joints, leading to inflammation, pain, and progressive joint destruction. When we say RA as an overlap CTD, we mean situations where RA features coexist with another autoimmune connective tissue disease, such as systemic lupus erythematosus, scleroderma, or myositis. These overlaps matter because they can alter the disease expression, treatment tolerance, and prognosis. For example, an RA-SLE overlap, sometimes called rupus, shows erosive arthritis typical of RA, but with lupus-like serology or cutaneous findings. Pathogenesis. Why does this happen? At the immunologic level, the process begins with autoimmune activation of synovial tissue. Here's what happens step by step. 1. Synovial antigen presentation. Environmental triggers, such as smoking or periodontal disease, can cause citrullination of self-proteins in genetically predisposed individuals. 2. Autoantibody generation. B cells and T cells mount an immune response, leading to rheumatoid factor RF and anti-citrullinated protein antibodies, anti-CCP. These antibodies not only serve as diagnostic markers, but also drive joint injury. 3. Inflammatory cascade. Cytokines such as TNF-alpha and IL-6 sustain the synovial inflammation. 4. Pannus formation. The inflamed synovium proliferates into a destructive layer, the pannus, which erodes cartilage and bone. When RA occurs as part of an overlap CTD, immune dysregulation extends beyond joints, involving multiple organs, lungs, heart, or skin, influenced by overlapping antibody profiles. Clinical features. How it presents. The hallmark is symmetric small joint polyarthritis involving MCP, PIP, and wrist joints. Patients typically describe morning stiffness lasting more than 30 to 60 minutes, improving with activity. Key features include tenderness, swelling, and warmth over small joints. Over time, chronic inflammation leads to deformities like ulnar deviation, swan neck, and boutonniere deformities. In overlap cases, you might also see skin thickening from scleroderma, malar rash from lupus, or myositis-related muscle weakness, depending on which CTD is overlapping. Extra-articular features are equally important. Rheumatoid nodules, interstitial lung disease, RA-ILD, vasculitis, pericarditis, or pleural effusions. Clinically, this makes it essential to move beyond just joint symptoms and think systemically. Investigations. What to look for and why. Let's talk investigations step by step. 1. Serology. Rheumatoid factor, RF, sensitive but not specific. Anti-CCP antibodies, highly specific and predictive of erosive disease. Presence of anti-CCP in a CTD overlap suggests that the arthritis component will behave aggressively like typical RA. 2. Inflammatory markers. ESR and CRP track inflammatory activity. These are useful for follow-up and treatment response. 3. Imaging. X-rays of hands and feet show periarticular osteopenia, joint space narrowing, and erosions. Ultrasound or MRI can detect early synovitis before erosions appear. 4. Organ assessment. PFTs and HRCT in suspected RA-ILD. Echocardiogram if pericardial involvement is suspected. These tests not only confirm RA, but also define its overlap character, identifying which systems need additional attention. Typical complications. Why we must be proactive if untreated. RA causes progressive joint destruction, deformity, and disability. Extra-articular involvement can cause rheumatoid lung disease, ILD, presenting with cough, dyspnea, and restrictive PFTs. Cardiac risk due to systemic inflammation accelerating atherosclerosis. Osteoporosis, both from inflammation and steroid use. In overlap cases, complications may be compounded. For example, a patient with scleroderma overlap might have pulmonary fibrosis worsening RA-ILD. Recognizing these interplays early helps us tailor immunosuppression and supportive therapy. Example clinical scenario. Let's take an example. A 45-year-old woman presents with 6 months of bilateral hand pain and stiffness, morning stiffness lasting over an hour, and swelling of MCP joints. She's anti-CCP positive, RF positive, and X-ray shows early erosions. However, she also reports mild Raynaud's phenomenon and has anti-nuclear antibodies, ANA positive. In this case, we should suspect RA as part of Overlap CTD, possibly with early scleroderma features. Why it matters. This overlap influences treatment. Methotrexate remains first line, but close monitoring of lung function is crucial because methotrexate may worsen fibrosis in those predisposed to ILD. That's why individualized DMARD selection guided by both rheumatologic and systemic considerations is so important. Classification and management. Why it matters classification helps us guide therapy, prognosticate, and coordinate multidisciplinary care. Treatment principles. Early diagnosis and treat-to-target approach, aiming for remission or low disease activity. Methotrexate as first-line DMARD unless contraindicated. Hydroxychloroquine or leflunomide as alternatives. Biologic DMARDs, TNF inhibitors, IL-6 blockers, or JAK inhibitors for resistant cases. Low-dose steroids as bridge therapy. In overlap CTDs, therapy may need to address systemic features. For example, if lung involvement is prominent, mycophenolate or rituximab might be chosen. If lupus features dominate, avoid methotrexate and favor hydroxychloroquine. The message is clear. Tailor therapy not only to joints, but to the whole patient. Clinicians' practical takeaway. For clinicians, 3 key take-home points. 1. Always think overlap when arthritis presentation seems atypical or multisystemic. 2. Order targeted tests early, especially anti-CCP and screening for other CTD antibodies. 3. Use a multidisciplinary approach, rheumatology, pulmonology, and sometimes cardiology, to optimize long-term outcomes. Rheumatoid arthritis as an overlap CTD reminds us that autoimmune diseases rarely read textbooks. Their presentations blend, evolve, and require us to integrate patterns rather than isolate labels. Our goal as clinicians is to identify the underlying immune pattern early, prevent irreversible damage, and individualize immunosuppressive strategies accordingly. End note, that concludes today's session on rheumatoid arthritis as an overlap connective tissue disease.